Good morning, Doc.
Okay, so let's start. Our topic for today would be acute kidney injury, about the laboratory assessment for kidney diseases. So our objective at the end of this session, the participants will be able to differentiate AKI from CKD, to know and understand the different stages and pathophysiologic categories of AKI, and to identify and use appropriate diagnostic tests in kidney diseases. So let's just review. You know that kidneys function is to regulate fluid, electrolyte, and acid-base status by filtration of blood, followed by selective reabsorption from or secretion into the tubules. So it is always filtration, reabsorption, and secretion. And kidneys has its endocrine function, like the regulation of bone and mineral metabolism by the active vitamin D, 125 dihydroxy vitamin D. Then the erythropoietin form the hematopoiesis, so it stimulates the bone marrow to produce red cells, and it regulates regulation of systemic and renal hemodynamics via the renin, angiotensin, aldosterone, and prostaglandin. So we all know that renal blood flow accounts for 20% of resting cardiac output, despite that kidneys only weigh 1% of our total body weight. So that's the reason why when we have hypotension, one of the organs that will be affected will be the kidney. Urine volume, we average have 1.5 liters a day, or approximately 1 ml per minute. This represents the sum of two large directional opposite processes. So one is ultrafiltration, and ultrafiltration has its more than 180 liters of plasma water per day, and reabsorption, practically 99% of the ultrafiltrate will be reabsorbed. So that's the reason why even if patients who have kidney failure, very poor kidney function, they will still have sometimes 1 to 2 liters of urine, but their actual filtrations might be just 10 liters, 10 to 15 liters of ultrafiltrates, which is just like less than 10% of the actual ultrafiltrate of a normal individual. So the normal GFR, it's about 130 to 145 liters per day in women, which is approximately 90 to 100 ml per minute, and 165 to 180 liters per day in men, or 115 to 125 ml per minute of GFR, which is the GFR is more than 10 times the volume of extracellular fluid and 60 times that of plasma. So the GFR is dependent on the blood flow to the glomerulus, the effective pressure across the glomerular capillary bed, the tubular pressure. So these are the factors that would affect our GFR. So what favors filtration would be the hydrostatic pressure in the glomerulus, which would mean indirectly is our blood pressure. The forces that oppose filtration will be the hydrostatic pressure of the Bowman space, the colloid osmotic pressure in the glomerular capillaries. So in a schematic diagram, what you can see, the principal force to affect, allow GFR to happen, filtration to happen, is the capillary pressure, which is our blood pressure. Then that would oppose with plasma or colloid oncotic pressure. So people who have hemoconcentration will also increase the forces that will decrease GFR. So interstitial fluid pressure is another one that would oppose. Interstitial fluid colloid pressure a little bit will contribute to filtration. So the decreased GFR. So if you have decreased glomerular hydrostatic pressure, like decreased blood pressure, like in circulatory shock, you'd expect to have a decreased GFR. If you have increased tubular hydrostatic pressure, as we see in urinary tract obstruction or tubular obstruction, then you would also have decreased GFR. Renal blood flow is reduced. So severe hypovolemia, cardiac failure, so effective intravascular volume is reduced, then that would also cause decreased GFR. Increased plasma colloid pressure, like in hemoconcentration, as I mentioned a while ago, would decrease GFR. Decreased permeability, like in diffuse glomerular disease. So if the glomerulus is already sclerotic, so you will have decreased permeability. Same thing in chronic kidney disease because of sclerosis and fibrosis. The nephron, there will be nephron loss, so your filtration surface area will also be decreased. How about the autoregulation of glomerular filtration? No, so even if we have a fluctuation of blood pressure, it does not affect that much, no, of the renal blood flow and no. So unless it's between 80 to 180, our autoregulation will regulate so that there will not be a very significant change in our renal blood flow and filtration rate. But the moment the blood pressure drops below 80, then the renal blood flow will be compromised and eventually the GFR will decrease. Same thing as a very high blood pressure. So what are the autoregulation? No? So first is the myogenic or the vasoreactive reflex. This is the first line of defense against fluctuation in renal blood flow. So the acute change in renal perfusion pressure evoke reflex constriction or dilatation of the afferent arterioles. So if you have an increased blood pressure, what would happen is you would have an acute change of vasoconstriction. And if there's a decreased blood pressure, there will be dilatation of the afferent arteriole. So afferent arterial smooth muscle wall constrict automatically when, as I mentioned, renal perfusion rises. The other autoregulation would be the tubuloglomerular feedback. So the macula densa cells sense changes in the volume delivery to the distal tubules. So experimental studies suggest that the decreased GFR slows the flow rate in the loop of Henle, causing increased reabsorption of the percentage of sodium and chloride ions delivered to the ascending loop of Henle. And this will decrease the concentration of sodium chloride at the macula densa. So when they sense that, it will initiate a signal that has two effects. So there will be decreased resistance to blood flow in afferent, so causes vasodilatation. This will raise the glomerular hydrostatic pressure and helps return the GFR towards normal or near normal. The other one, it will increase renin release from the juxtaglomerular cells of the afferent and efferent arterioles. So what is a renin? It is a potent vasoconstrictor. It will stimulate the angiotensin to angiotensin and angiotensinogen to angiotensin, which is angiotensin is a potent vasoconstrictor that will constrict the efferent arteriole, so further increase the glomerular hydrostatic pressure. So these two helps in maintaining the glomerular pressure, even if there's a fluctuation in our blood pressure. So yeah, this is the summary. So you have, if you have a decreased arterial pressure, what would happen? You have a decreased hydrostatic pressure and decreased GFR, but this will be sensed by the macula densa, so it will stimulate increased proximal sodium chloride reabsorption, and it also will stimulate angiotensin 2 renin that will cause conversion of angiotensin 1 to angiotensin 2, then this will also cause vasoconstriction of the efferent that would eventually cause increased glomerular pressure. So in a normal perfusion pressure, so what happened, that this is the afferent, then this is the efferent. When you have a decreased pressure, what would happen? You would have increased prostaglandin that will cause vasodilation, and it will increase angiotensin 2, as I mentioned, and will cause vasoconstriction. So with the vasoconstriction of the efferent and dilatation of the afferent, the glomerular pressure will increase. The problem would be when you have you take NSAIDs. What does NSAID do? NSAID will decrease the prostaglandins. So if there's a decreased pressure, the afferent arterioles will not vasodilate because of the decreased level of prostaglandin. So you will have decrease here. So you will end, the blood flow to the glomerulus will be decreased. So you will end up having low GFR. When you are taking ACE or ARB and there's a decrease in pressure, so what would happen is the ACE will vasodilate the ACE or the efferent arterioles. So you have a normal vasodilatation or normal afferent arterioles, so the blood flow. But since you are also dilating this one, the efferent, the actual glomerular pressure will decrease. The one that might will definitely precipitate acute kidney injury would be a combination of NSAIDs and an ACE. No, so the patient is taking ACE and you give an NSAID. So the NSAID, what will NSAID do? It will decrease prostaglandin. So there will be vasoconstriction of the afferent. So further decrease of the GFR. Is there any questions so far? You still follow? Feel free to type in the chat if you have some question, or you raise your hand so I can stop. So about acute kidney injury. It has traditionally been defined as an abrupt loss of kidney function over hours or days that result in retention of urea and other waste product, and in this dysregulation of extracellular fluid volume. So that's why you will have volume overload and electrolytes imbalance. The term acute renal failure is now reserved for severe acute kidney injury, usually implying the need of renal replacement treatment. The loss of kidney function is most easily detected by measurement of serum creatinine, which is used to estimate the GFR. So the acute kidney injury, sometimes the patient would not have, initially would not have any symptoms yet. AKI complicates 5 to 7% of hospital admissions and up to 30% of ICU admissions. This is associated markedly with increased risk of death in hospitalized patients. This is also common even during COVID. Patients with COVID pneumonia, when they develop acute kidney injury, the risk for mortality is higher. 50% mortality rates in ICU patients. Despite of the improvement of the management in AKI, we still have approximately 50% mortality rate in ICU. It increases the risk of development of or worsening of the chronic kidney disease. AKI requiring dialysis are at increased risk of later development of dialysis requiring ESRD. No, so this one, AKI, the outcome would it be? It could be they could recover if they survive. Their kidney function can recover fully or partially, but some would not even recover. That would end up being dialyzed dependent for the rest of their life. So AKI can be community acquired or hospital acquired, but most commonly AKI is hospital acquired. So some causes of AKI are region specific, especially for those with infectious diseases and for those taking herbal medications and other causes. No, so what are the common causes of community acquired AKI? The common would be volume depletion. So the patient had diarrhea, severe diarrhea, then they might go into patients who have chronically having heart failure, then exacerbated congestive heart failure, predispose them to become class 4E before coming into the hospital, so they would have AKI by that time. Adverse effects of medications, so patients who have borderline kidney function, then they take like NSAID, as I mentioned a while ago, so the very common, even the Alaxan, that's paracetamol plus ibuprofen. Ibuprofen is one of the NSAID, no? So some would also take COX-2 inhibitors like the celecoxib, etorocoxib, that can cause vasoconstriction of the afferent and predispose patients to AKI. Obstruction of urinary tract, either stones or enlargement of the prostate. So malignancy. The common clinical settings for hospital-acquired AKI, the most common will still be sepsis, major surgical procedure, critically ill patients involving heart or liver failure, using IV iodinated contrast administration in patients who will undergo CT scan with contrast, or patients who would undergo angiography. Nephrotoxic medication administration, so like aminoglycosides, vancomycins, NSAIDs. So the loss of kidney function that defines AKI is most easily detected by measurement of serum creatinine. So 3 problems are associated with the use of the serum creatinine to quantitatively define AKI. 1, serum creatinine does not accurately reflect the GFR in a patient who is not on the steady state. So if the patient is in hypercatabolic, it does not truly reflect the creatinine does not truly reflect the GFR. Creatinine in patients already AKI and that needs dialysis, creatinine is removed by the dialysis. So with that, you cannot use creatinine to follow-up, no? The improvement. So numerous epidemiologic studies and clinical trials have used different cutoff values for serum creatinine to quantify AKI. So there's no standardized value. No? So the AKI, the stages, there's actually 3 that we use: the rifle criteria, the Akin criteria, and the KDIGO. So the rifle is the first one in early 2000. So rifle means risk, injury, failure, loss of kidney function, and E is for end-stage kidney disease. Akin trial is it takes off from the rifle criteria. So this acute kidney injury network. Then the KDIGO guide staging is brought about by the Kidney Disease Improving Global Outcome, spearheaded by the International Society of Nephrology. So rifle criteria, risk, you consider it risk if there's a 1.5-fold increase in serum creatinine or a decrease of GFR by 25%, or a urine output of less than 0.5 ml per kilo per hour for the past 6 hours. You consider it as injury if there's a 2-fold increase in serum creatinine or a decrease of GFR by 50%, or a urine output of less than 0.5 ml per kilo per hour for the past 12 hours. Failure, when there's a 3-fold increase in serum creatinine or 75% decrease in GFR, and decreased urine output for 24 hours of less than 0.5, or a complete anuria for the past 12 hours. Loss, it means complete loss of kidney function. It would need renal replacement treatment for more than 4 weeks. ESRD, it's a complete loss. So the patient is still dialysis dependent for more than 3 months. Then you consider that patients who have acute kidney injury to have end-stage renal disease. The limitation of rifle criteria, the risk, the injury, and the failure strata are defined by either changes in serum creatinine or urine output. Unfortunately, sometimes we don't have the baseline creatinine, and the corresponding changes in serum creatinine are not based on evidence. In one assessment rifle classification that compared the serum creatinine and urine output criteria, the serum creatinine criteria were strong predictors of ICU mortality, whereas urine output criteria did not independently predict mortality. So with this, when there's a discrepancy, we always tend to use the higher stage based on the serum creatinine. So the change in serum creatinine during AKI, as I mentioned, does not directly correlate to the actual change in GFR. So authors of the rifle criteria suggest back calculating an estimated baseline serum creatinine using a 4-variable MDRD equation, assuming that the baseline GFR is 75 ml per minute. However, this approach has not been prospectively validated. So how about Akin criteria? This is a modification of the rifle criteria, then has been proposed in 2004. So Akin proposed both diagnostic criteria for AKI and a staging system that was based on rifle criteria. In addition, the term AKI was proposed to represent the entire spectrum of acute renal failure. So Akin criteria definition of AKI would be an abrupt, within 48 hours of absolute increase in serum creatinine concentration of more than 0.3 milligrams per DL from baseline, or a percentage increase in serum creatinine concentration of more than 50%, or an oliguria of less than 0.5 ml per kilo for more than 6 hours. So the caveats for this proposed Akin criteria: the diagnostic criteria should be applied only after volume status has been optimized. So it means initially when the CREA is high, the creatinine is high and BUN is high, but the patient is dehydrated, you have to hydrate that patient. After hydration, you would have to repeat the CREA and BUN and use that as the criteria for staging the AKI. Urinary tract obstruction needed to be excluded if oliguria was used as a sole diagnostic criterion. You just make sure that the bladder is not distended. No? Kaya pala anuric because of obstruction. So this is the staging, stage 1, 2, and 3. So stage 1 is more than 0.3 milligrams per DL increase, or 1.5 to 2-fold increase from baseline, when the urine output would be less than 0.5 ml for 6 hours. For stage 2, increased serum creatinine of more than 2 to 3-fold from baseline, and urine output of less than 0.5 per kilo per hour for the past 12 hours. And stage 3, increased serum creatinine more than 3-fold from baseline, or a serum creatinine of more than 4 milligrams per DL, with an acute increase of at least 0.5 milligrams per DL. And urine output of less than 0.5 ml per kilo per hour for the past 12 hours. Whereas the KDIGO AKI definition, the more or less the same: increased serum creatinine within 48 hours, increase in serum creatinine more than 1.5 times the baseline, which is known and presumed to have occurred in the prior 7 days. Urine volume of less than 0.5 ml per kilo per hour for the past 6 hours. So this is the staging, stage 1, 2, and 3. So the serum creatinine, 1.5 to 1.9 times the baseline, or more than 0.3 milligram per DL increase, with a less than 0.5 ml per kilo per hour for 6 to 12 hours. Whereas stage 2 is 2.9 times the baseline, with less than 0.5 ml per kilo of urine per hour for the more than 12 hours. So stage 3, it's either 3 times the baseline, or increase serum creatinine to more than 4 milligrams per DL, or the patient would need renal replacement therapy. In patients younger than 18 years old, a decrease of estimated GFR of less than 35 is considered stage 3. And less than 0.3 ml per kilo per hour of urine for the more than 24 hours, or anuric for more than 12 hours. So these are the staging based on KDIGO. At present, most of us, the nephrologists, use KDIGO staging for AKI. So this is a summary of the difference between the 3 criteria. No? So clinical evaluation of AKI may be achieved by answering following questions. You ask this in your is it AKI or acute on top of chronic? It means that AKI, it means purely AKI. It means the patients had normal kidney function, then suddenly had a problem. Or the patient has a stable chronic kidney disease, then suddenly deteriorated. So that's an acute on top of chronic kidney disease. Is there any renal tract obstruction? So when you're asked to evaluate, look, check. If it's a male, you have to do a rectal exam, palpate the bladder if it's not distended. Then you might do an ultrasound to see if there is an obstruction due to stone. Is there reduction in effective extracellular fluid volume, like in patients with congestive heart failure or in patients with liver cirrhosis? Has there any major vascular occlusion? Is there parenchymal renal disease other than ATN? So those are the clue, the things that you would have to look for in evaluating patients with AKI. So a very careful history and PE would help. So first, careful history. You want to know if the patient has potential risk for acute of chronic kidney disease, like patients who have diabetes, hypertension, history of stones, history of chronic intake of NSAID, chronic intake of probably food supplement or herbal that might predispose. So physical exam in AKI, when you're evaluating for AKI, you would want to see signs of dehydration or volume depletion. So aside from the PE of decreased turgor, dry buccal mucosa, you would want to see if there is a postural hypotension. So postural hypotension, are you familiar with it? So you take a blood pressure of patients in supine, and you get a blood pressure of patients on standing or sitting with dangling. If there's a decrease in blood pressure of more than 20 millimeter mercury, that is postural hypotension. It means that the loss, either by dehydration or blood loss, is significant. So that one. Then for patients with AKI secondary to congestive heart failure, so you see if there's signs of volume overload, signs of congestive heart failure. Very important also is to review all the medications you have to ask. And when you get a history, when you ask a patient of what are they taking medications, they would always tell you about maybe medications for hypertension, diabetes. But the whole bunch that they take of food supplement, they will never mention it that to you unless you ask, no? Because for them, that is not medicine. So you will have to ask them, what are the medications that they're taking, the prescribed and their own self-medications, and the food supplement that they have started. And very important would be probably the time frame when they start. So a very important patient that was started with ACE inhibitors on an elderly individual for hypertension or ARB, then they have a baseline normal creatinine, then 3-4 weeks later, the crea went up. So you would have to ask Sorry, where did I stop? Hello? Can you hear me?
Yes, Doc.
Saan ako naputol? Still in the review of medications?
Yes, Doc. You'll stop back. You'll have to ask them and then pause
Okay,
ka.
sige. So naputol kasi, sorry about that. So as for the medications, you would, aside from asking what medications the patients are taking, you for the new ones, you would have to ask how, since when were they taking the medications, because the time frame would be important, especially in other particular medications like the prescribed medications like ACE inhibitors and ARB. This is very significant in elderly individual because they might have asymptomatic renal artery stenosis that would predispose them to AKI when you start ACE or ARB. So the three major causes of AKI, the pre-renal, the intrinsic, and the post-renal. The most common would be the pre-renal, 30 to 60%. This is caused by hypoperfusion resulting to decreased function without a frank parenchymal damage. Most of the, if this is not corrected, it can go into ATN, which is part of the intrinsic AKI, plus the other glomerulonephritis. There's the actual involvement of renal parenchyma. Post-renal AKI, which is less than 10%, is associated with urinary tract obstruction. So these are the causes, no? So AKI, pre-renal, so hypovolemia, decreased cardiac output, decreased effective circulating volume, like in, as I mentioned, CHF and liver failure, then impaired renal autoregulation in patients who are taking NSAID ACE. Cyclosporine is an immunosuppressive medications that can cause vasoconstriction. For intrinsic, so for this problem, especially hypovolemia, decreased cardiac output, and decrease in effective circulating, if it is left untreated, can cause an tubular and interstitial problem. So this is the ischemia. So other causes would be an acute glomerulonephritis. It could be vascular, in vasculitis, in malignant hypertension, in the TTP HUS, no, hemolytic uremic syndrome. So for the tubular and interstitial, so you can have the extension uncorrected pre-renal can cause to lead to ischemia and ATN. The other would be directly because of the cytokines and because of that's the sepsis and infection. Then nephrotoxins. It could be exogenous, like when you give the dye, the iodinated dye, in CT scan or in angiogram. So the giving of aminoglycoside, the cisplatin. So cisplatin for a chemotherapy drug that can cause tubular damage. Then amphotericin B is an antifungal. PPIs, the is being used left and right, like the omeprazole, pantoprazole. It has already found out that can cause tubular problem, tubular interstitial diseases, and NSAIDs also. So endogenous, when you have hemolysis, the hemoglobin can precipitate sa tubules and cause AKI, ATN on it. So rhabdomyolysis, so it's the myoglobin that would precipitate in multiple myeloma, and in the crystals, the increased crystals can cause tubular damage. For post-renal, this is usually bladder outlet obstruction. So it's either from the prostate that would have a bladder outlet obstruction, or a bilateral kidney stone ureteral, one kidney stone on the other side, or both ureteral stone, and unilateral obstruction, but on a solitary functioning kidney. So that would cause a post-renal AKI. So this is just in detail, no, the cause. So volume depletion can be renal loss, GI loss, or hemorrhage. Decreased cardiac output, either right or left-sided heart failure, cardiac tamponade. Systemic vasodilatation that we see in sepsis, anaphylaxis, and giving of anesthetics. Afferent vasoconstriction when we give NSAID. So the cyclosporine is a calcineurin inhibitor. The other calcineurin inhibitors is the tacrolimus. When you give radio contrast medium, the patients with hepatorenal syndrome and the hypercalcemia. Hypercalcemia can cause afferent vasoconstriction. Efferent vasodilatation is the ACE and ARB. So for intrinsic tubular injury, so it could be ischemic, as I mentioned. So this one is due to the uncorrected prerenal or nephrotoxic drug, or nephrotoxic because of pigment. So rhabdomyolysis, that would be myoglobin. Intravascular hemolysis would be hemoglobin. Acute interstitial nephritis could be drug-induced. So most antibiotic can probably cause acute interstitial nephritis in patients. No? Then infection related can also cause interstitial nephritis, autoimmune diseases, and malignancy. So tubular obstruction, like the crystals, so acute increase of crystals, no, like in tumor lysis syndrome, or the abuse of ethylene glycol. The ethylene glycol, we don't see it here. It's more common in the East, Western, no? Okay, it's cold. So some people, homeless people, would take it because they're too cold. Then for intrinsics, a GN would be one. So commonly would be post-infectious SLE, rapid progressive glomerulonephritis. Macrovascular, there's an increased renal vein pressure, bilateral vein thrombosis, or bilateral renal artery emboli. The microvascular that you see in atheroembolic diseases, scleroderma, in renal crisis, in malignant hypertension. So post-renal, that's the one I mentioned. So these are the common, you can look at that. I mean, just to know, you don't have to memorize this. So different plant and where they are common, no? So these are the renal manifestation nila. So flavonoid. Actually, flavonoid is used natin sa the one being used for hemorrhoids, like the Daflon. There's flavonoid. So that's why patients who develop AKI, you have to review if they have the Daflon and that medications. You might have to withdraw first to observe if the kidney function will improve. Colchicine, that is used for acute gouty arthritis, can cause AKI. So this is the common causes of AKI in patients with cancer. So post-chemotherapy, they keep on vomiting, they would get dehydrated, or they would have a vascular due to thrombotic microangiopathy. They can develop GN because of either their malignancy or their chemotherapy drug. So ATN can happen because of sepsis, because of antibiotic nephrotoxicity, and some cancer would cause hypercalcemia. So they would also present as ATN. So malignant infiltration of the kidneys in patients with lymphoma and acute lymphoblastic leukemia. Intraluminal obstruction, this is seen in tumor lysis syndrome. So patients with myeloproliferative malignancy like leukemia, lymphoma, when they are given chemotherapy drug, the rapid destruction of cells. So there's an acute rise in uric acid because of the destruction of cells. So if the patient had no pre-medication of medications that will lower uric acid, it will predispose patient to tumor lysis syndrome. Cas nephropathy is when you would have hepatitis, acute fulminant hepatitis. So the bilirubin, the hyperbilirubinemia can cause cas nephropathy. Post-renal obstruction also can be seen in patients who have bladder CA. So chemotherapeutic agents that are nephrotoxic, these are the common ones: cisplatin, efosfamide, plicamycin, and 5-FU. For acute causes of AKI in liver disease, the most common is still pre-renal, So usually due to diuretic use, because most of them would have been given spironolactone to prevent accumulation of fluid, sa ascites. So they will be using that. Then there's gastrointestinal loss, peritoneal aspiration, and because of hypoalbuminemia. So it predisposes them to have increased edema, so sa extra cellular, more of interstitial. So the other one would be hepatorenal syndrome. You can have ATN. So it could be drug induced, like when they're taking these medications like acetaminophen, NSAID, tetracycline, rifampicin, INH, anesthetic agents. Infection. So hepatitis C and cryoglobulinemia, hepatitis B can cause polyarteritis nodosa. Then leptospirosis itself can cause AKI. Then the other viral infection. So what happened in AKI? So initially it's normal. You would have an increased risk. Elderly, then what would happen is there's a damage. Then there will be decreased GFR, and some would have kidney failure. So complications, all the complications like volume overload, electrolyte imbalance can happen. If it will not recover, what would happen? There will be end stage or death of the kidney function or death of the patient itself. So next would be how to differentiate AKI from CKD. And now there's a proposed category of a subacute kidney disease. So an acute kidney injury, as I mentioned, that is developed within hours or days, and the most common would be in hospitalized patient, and then the chronic kidney disease and elevated creatinine or other evidence of kidney damage like proteinuria in the imaging that is present and relatively stable, and it is present for more than 3 months. Now, the proposed subacute kidney injury develops more slowly than AKI, but generally result in worsening of creatinine over the course of few weeks. The AKI is more of the 48 hours ang kanilang ikino-consider. But this is still the proposed by the KDIGO. No? So they propose the term acute kidney diseases and disorder. This will combine both the AKI, which is less than 48 hours, and the subacute, the slower, that happens through days and weeks. But then to differentiate it from chronic kidney disease, that it should be there more than 3 months. So what are the diagnostic tests that we can use, no? So to assess renal function. So the most common, as I mentioned, serum creatinine, the blood urea nitrogen. You estimate the creatinine clearance of the EGFR by the different formula based on the creatinine and the age and the gender of the patient. The inulin clearance, the creatinine clearance, and the nuclear GFR. So let's discuss one by one. Creatinine is an endogenous substance mainly produced in the muscle cells from creatine and phosphocreatine. So creatinine is freely filtered, not reabsorbed, but can be secreted by the tubular cells. What is the, sana ang pinaka ideal substance that will estimate GFR would be, it should be freely filtered, not reabsorbed, not secreted. But the reason why we're doing creatinine is it's endogenous, so we just get it, no? So it's easy to measure. So, but problem is the secretion is very low if you have a normal kidney function. But as your kidney function deteriorates, that would mean your plasma creatinine So low creatinine productions, we see this in constitutionally small muscle mass, like in women and in patients with amputee. So the patient with diabetic kidney disease, usually diabetes would have problem, then they would have wound, then they would have amputation below knee or above the knee. So in patients with that, you have to watch out if the creatinine, although you know that the creatinine, normal creatinine is 0.6 to 1.2, if you see that in an amputee of a creatinine of 1.2, that you would have to investigate that the patient may probably have kidney problem, no? Also in very small female, maybe less than 50 kilos, and the crea is above 1, you would have to think of investigate that the patient might have kidney problem also. And a creatinine of 1 in patients of different age group and weight would mean different estimated GFR. So a 1 in a 70-year-old woman and a 1 in an 20-year-old man, 70 kilo, would be a totally different interpretation of eGFR. So that's why we need to compute for eGFR, which we will discuss later. So low production of creatinine will also happen in muscle wasting and in malnutrition. So substance would influence creatinine measurement. In Jeff's reaction, it will be glucose, ketones, and all cephalosprins may increase creatinine. Hyperbilirubinemia may cause decreased creatinine measurement. Using enzymatic method, hyperglycemia might increase the creatinine measurement. The ethoxylate and metamizole will decrease the creatinine measurement. There are drugs that might block tubular secretions of creatinine. That would mean when you measure, it's slightly increased on creatinine, but that doesn't make a reflection that the GFR is low. No. So what are these? So trimethoprim, the part of the trimethoprim sulfa, which is an antibiotic, can cause blockage. Cimetidine is an old generation H2 antagonist. Probenecid, this is not available anymore in the market in the Philippines, but this is usually we used to give that to delay the excretion of a certain medications, not to prolong the action. So as of now, we don't use that. Amiloride is a diuretic. It's a diuretic. Spironolactone is also a potassium-sparing diuretic. Triamterene is a diuretic also. So how about the creatinine clearance? So creatinine clearance is the measurement of the urine creatinine plus the volume of the urine divided by the plasma creatinine. So the V there is urine flow rate, which is cc per minute. Urine creatinine is measured in milligrams per DL. You measure the V there, the urine flow rate, by dividing the volume of the urine in cc divided by the number of minutes per day, which is 1,440 minutes. So if you have a 2,000 ml urine that was collected, divided by 1,440, so it's about 1.2 cc per minute will be the urine flow rate. So how do we measure creatinine clearance? No, so the creatinine clearance using a 24-hour urine collection for creatinine clearance is a little tedious thing to do. No, so first is you instruct the patient to void first thing in the morning. So they take note of the time. If they voided at 7 in the morning, they take note of the time, but the first urine should be discarded. Then the succeeding urine thereafter should be collected, every single drop, until the following day. So if the initiation, the first urine that was discarded was voided at 7 in the morning, the urine has to be collected until 7 in the morning the following day. So you have better emphasize to the patient that they have to void at 7 a.m. also. So if they miss out some of the urine, they accidentally voided directly to the toilet, then they have to start all over. Otherwise, it's useless, no? So, and before interpreting the creatinine clearance result, you have to check for the adequacy of the collection. So you're not there to see if the 24-hour urine collection was adequately collected, but there's a way to check the adequacy. So urinary creatinine excretion is relatively constant. For ages 50 years or younger, in men, it's 20 to 25 milligram per kilo per day, whereas in women, it's 15 to 20 milligram per kilo per day. In patients with 50 to 90, there's a progressive decrease of about 50% in the creatinine excretion. So more or less, the patient might have just 10 milligram per kilo per day of excretion. So to check for the adequacy is you check the 24-hour urinary chorea of the patient divided by the weight of the patient. So for example, the patient is 50 kilogram. Then the 24-hour urinary chorea is 1,000 milligram. So 1,000 divided by 50, then that's 20 milligram per kilo. So with that, that is adequate. So whereas, for example, the 24-hour urinary chorea of a 70-kilo man who's collecting for 24-hour urine collection has only been 600. So 600 divided by 70, that's about 8 milligram per kilo. So that is inadequate collection. So disregard the result and ask the patient to have another collection. You still follow? Nakuha niyo na? So that's how you check for the adequacy. So the most common that we use for estimating GFR or creatinine clearance based on serum creatinine was the Cockcroft-Gold formula. So this is 140 minus the age of the patient times the weight in kilogram divided by the product of 72 times the serum or plasma creatinine in milligrams per DL. So for women, the result of this, you multiply it by 0.85. That's a Cockcroft-Gold formula. With that, you can use ordinary calculator to estimate GFR, no? But if you're using international unit, the micromole per liter, this is the formula. Or if the result is in micromole per liter, you just divide it by 88.4 because this one is easier to remember, diba? So either way, you can use that formula. Then for female, it's a separate, it's times 1.04. The other formula would be the MDRD study equation. So this one is more complicated to use manually, but this is available in Med Calculator. No, so the factors that the parameters that they need would be the creatinine, the serum creatinine, the age of the patient, the BUN, the albumin, and if the patient, the gender of the patient, and the race, no, if it's Black or not. So those are the factors that being used. The other one, the abbreviated MDRD, will only use the plasma creatinine or serum creatinine, the age of the patient, the gender, and if the patient is African American. So the MDRD GFR equation is only used for CKD, not accurate for AKI, no? And please also note that the recent study indicates that they may underestimate the actual GFR in healthy patients by 29%. So if you're using a medical, this is what you will see, that you encode the age, the serum creatinine, the gender of the patient, and the race. Then the GFR will come out. That's ml per 1.73 meters squared. So if the patient is bigger or smaller than that, then you can also compute. For CKD-EPI equation, the CKD-EPI equation is comes out nearer than the other formula, no? So this one will also consider the age, the gender, the race, and the serum creatinine. So when you encode that, when you input that, then you will find the GFR also in 1 per 1.73 meters squared body surface area. So this the one here is just showing what the formula, no, but it's hard to compute it not using a scientific calculator. So our life is easier now with a medical calculator, but I still show it to you just for you to be familiar and know that what are the component of the equation. Then recently in 2021, the CKD-EPI was changed, no? And they're trying to recommend this because they removed the race, no? Because with before the CKD-EPI, that would only be good for the black race, but because all the rest of the race will have an underestimation of the GFR. So now the CKD-EPI equation of 2021 was published in September of 2021. Then majority of the experts are now recommending to use the CKD-EPI equation 2021 to estimate the eGFR of a patient. Next test that can be used would be blood urea nitrogen. This is a major excretory product of protein metabolism. This is readily absorbed, readily filtered. Unfortunately, it is readily absorbed by passive diffusion, 40 to 80%. So it is very dependent on the state of hydration of a patient. Urea nitrogen constitute about the total urinary solids and 80 to 90% of urinary nitrogen. So plasma urea is not only affected by renal function and perfusion, but also state of hydration, the level of protein metabolism, and also the intake of protein. So if you take 8 ounces of steak and you get a BUN, your blood urea nitrogen after a few hours will increase. So, but that doesn't mean that your kidney function had decreased. So what is more helpful would be the BUN creatinine ratio. So normal adult in normal diet is usually have the 10 to 20 BUN creatinine ratio. So high ratio with normal creatinine where do you see this? In patient with dehydration. So the Crea of 1, but the BUN is 40. So the patient was having a diarrhea or was using diuretic, then that is due to that, no? So it could also be seen in patients who are taking high protein intake. So patients who are doing bodybuilding, who are loading themselves with high protein diet, would have a high ratio of BU and creatinine ratio. There's an increased tissue breakdown, and also in GI hemorrhage, no? So because in GI hemorrhage, the blood is in the intestine, but as it passed through the intestine, it is di ba metabolize and disintegrate. So the urea is being reabsorbed by the intestine. So the BUN is relatively higher. So when you have a BUN way higher than the creatinine in the BN, more than 20 BUN creatinine ratio, those are the things that you would have to rule out or rule in: the dehydration, high protein intake, increased tissue breakdown, or GI hemorrhage. So what is more important clinically would probably the GI hemorrhage and the dehydration. High ratio with elevated creatinine, now that you see that in pre-renal or a post-renal azotemia. Low ratio, you would see that in starvation, severe liver cirrhosis, disease, low protein intake, and in acute tubular necrosis. So what are the other tests, no? One test that they have tried would be the cystatin C, but it's not commercially available in all regions. In Cebu, we don't have it. It's a low molecular weight protein that is a member of superfamily cysteine protease inhibitors. It is filtered at glomerulus and it's not deabsorbed, but it is metabolized in the tubules. So that's the reason why, since it's metabolized in the tubules, we cannot use it for clearance, cystatin clearance. It means urinary clearance. We cannot, because it is underestimation, no? Because it is metabolized in the tubules. Cystatin C is thought to be produced by the nucleated cells, and its rate of production has been thought to be relatively constant and not affected by changes in the dye, although this is not proven. And cystatin C level is increased sharply with age. As of the moment, there's still no standard cystatin C measurement. So these are the endogenous comparison of the endogenous filtration markers for estimation of GFR, the creatinine, the cystatin, and the urea, the blood urea nitrogen. So in terms of weight, it is higher, no? Ang cystatin. So generation varies according to the muscle mass, the dietary protein, and it's lower in elderly, women, and in whites. So whereas cystatin C is thought to be mostly constant by all nucleated cell. It increased in hyperthyroid state or with steroid use, and lower in elderly and in women. Urea nitrogen, as I mentioned, would vary accordingly based on the intake of the protein and the state of hydration. The handling, so the difference, this is filtered, secreted, excreted. The cystatin, filtered, reabsorbed, and catabolized. Whereas urea is filtered, reabsorbed, and excreted. Extrarenal elimination, yes. increases as we have reduced GFR. Preliminary evidence of increases as reduced GFR also. BUN also yes. So there's still no perfect endogenous filtration marker at this point. So as of now, it's still the endogenous filtration marker that we can use is still the serum creatinine. Inulin clearance, this is actually the best marker, Sana, because it's freely filtered, not reabsorbed, not secreted, not synthesized, not metabolized. So this is the ideal marker, but unfortunately it is an exogenous. So since it's exogenous, for you to measure the clearance, it has to be continuously infused. So now in clinical practice, we do not use this. So it's more of for research. So the one that we use and become can approximate the inulin clearance is the nuclear GFR. So they use nuclear medicine as the marker, no? So it's either the iotalamate, the technetium DPTA as filtration marker. So commonly we use the 99 technetium DPTA simply because has a shorter half-life. So when it has to have a shorter half-life, it minimizes radiation exposure. Sorry, but these markers is still secreted, But the reason why it still approximate inulin clearance because we give a fixed concentration, so the secretion is also fixed. So it becomes I don't know, negligible because it's a fixed level. Unlike serum creatinine, it increases as your kidney function deteriorates. Whereas ang nuclear GFR, we give a fixed dose of filtration marker. So the exogenous, so the gold standard, as mentioned, is inulin, but it needs to be a continuous infusion. Whereas the rest is bolus IV or sub-Q. So the iotalamate can be administered as radioactive compound with iodine 125. Whereas technetium DPTA, dissociation of technetium 99 leads to plasma protein binding and underestimation. So the iotalamate is overestimation, the technetium DPTA is underestimation. The EDTA is 10% lower than the inulin. The iohexol, low incidence of adverse effects, say using HPLC, lower urinary clearance than iotalamate. The other biomarkers of AKI, one is the neutrophil gelatinase associated lipocalin, the NGAL. This is markedly upregulated and abundantly expressed in kidney after renal ischemia. It may function to dampen toxicity by reducing apoptosis and increasing the normal proliferation of kidney tubular cells. So by enhancing the delivery of iron, the NGAL upregulates the heme oxygenase 1, hereby protecting kidney tubules. So that's why the NGAL is found in the urine of patients who have AKI. No? This is also known as the lipocalin-2 or siderocalin. So NGAL shows a promise as a biomarker to help diagnose early ATN. Elevated urine and gall levels may predict the development of AKI. In prospective study of 451 critically ill patients, NGAL independently predicts severe AKI with a haphazard ratio of 2.6. A similar finding was observed in 100 adult cardiac surgery. NGAL predictive value increases also with severity of AKI. The average sensitivity and specificity of NGAL ranges between 73 to 76 sensitivity and 77 to 80 specificity. So this one, even it predicts AKI 1 to 3 days prior to the diagnosis of AKI. So hoping that it might help, but the problem is still the cost, and there's still no standardization. So we're waiting for more studies and more improvement to the measurement. The other biomarkers that they're looking into is the kidney injury molecule 1. So it's a type 1 transmembrane protein that is abundantly expressed in approximately in proximal tubule cells that are injured by ischemia or nephrotoxin. Then the other one is urinary interleukin 18. It has been shown to be elevated in patients with ATN compared with patients with pre-renal or UTI or CKD. So there are still ongoing research, so they are still not standard. The other one would be the urinary liver type fatty acid binding protein, the LFAPB. It reflects stress of proximal tubular epithelial cells and correlates injury with severity of ischemic tubular injury. The other one is the SUPAR, the soluble urokinase plasminogen activator receptor, the circulating form of membrane-bound urokinase plasminogen activator receptor. It is a glycosyl phosphatidyl inositol anchored protein normally expressed on endothelial cells, podocytes, with induced expression on monocytes and lymphocytes. So these are all experimental pa. So the LFAPB are now commercially available, but it's not available in all centers, and it's a little expensive, So the biomarkers ranges between mga 1,500 to 4,000 pesos. And can you still hear me clearly?
Yes, Doc.
Okay. So these are the biomarkers that are on studies in relation to the site of injury. So tubular, you see serum creatinine, BUN, cystatin, and GAL might be helpful. For glomerular injury, you would want to see the albumin excretion, the podocyte count, and the podocalcin. Then for other injury not specific to the nephron, you can use the hepcidin iron. So these are all experimental. Then if it's a tubular, so the ATN, that's the one that helpful for the mga biomarkers, the interleukin, the cystatin C, the LFABP. So these are the things that would be needed. So distal tubule and GAL would be helpful. So next would be the urinary diagnostic indices in AKI. So you would want to see the urine specific gravity. Urine specific gravity would be helpful for as long as there's no proteinuria and a lot of cells. So if you have more than 1.020, most likely the patient had pre-renal. But if there's proteinuria and hematuria or pyuria, your specific gravity will go up and will not be helpful. No, intrinsic renal, usually you would have 1.010. Urine osmolality, you have higher urine osmolality in pre-renal because the kidney would try to reabsorb water. So you have a more concentrated. So the urine specific gravity and urine osmolality just simply say you have a very concentrated urine for pre-renal. And for intrinsic, since the tubules are damaged, it cannot the urine cannot be concentrated. For plasma urine creatinine ratio, so as I mentioned, for pre-renal or dehydration, you have more than 20. For intrinsic, it would be normal. Urine sediments, pre-renal might be nothing, you don't see anything, or you might see hyaline cast, which is a normal cast that can be seen in a normal urine. For intrinsic renal, especially ATN, muddy brown cast is seen in acute tubular necrosis. For fractional excretion of sodium and renal failure index, I'll discuss it later. Urinary sodium, same thing, because you're trying to conserve the fluid, so sodium would be reabsorbed together with fluid, so that's the reason why you have a very low urinary sodium in pre-renal. In intrinsic, you have a damaged kidney, so it cannot completely reabsorb sodium. Urine urea and plasma creatinine ratio, it's higher in pre-renal. Same thing as urine urea and BUN ratio. So what is fractional excretion of sodium? It's a fraction of the filtered sodium load is reabsorbed by the tubules. No? A measure of both kidneys' ability to reabsorb sodium as well as the endogenously or exogenously administered factors that affect tubular reabsorption. So fractional excretion of sodium depends on sodium intake. Effective intravascular volume is the GFR, the diuretic intake of tubular reabsorptive mechanism. So fractional excretion of sodium, you do not measure it if you have given in the patients with AKI, if patients were given diuretics, any form of diuretic, fractional excretion of sodium will be useless, no? Because the sodium will be high. So fractional excretion cannot be used, no? Unless you wait, like if the patient received furosemide, which has an action of 6 hours, so you can withhold the succeeding dose of furosemide and take a fractional excretion of sodium the following day. Then it would reflect a true fractional excretion of sodium. So how do you measure? How do you compute? So urinary sodium divided by the serum sodium. So the quotient of urinary sodium and serum sodium divided by the quotient of urine crea and serum creatinine. Then you multiply it by 100, sorry. So whereas ang renal failure index is urinary sodium divided by the quotient of urinary crea and plasma creatinine. So what is the significance of fractional excretion of sodium? You see more than 1% of fractional excretion of sodium in ATN, in non-absorbable solute like if you have infusion of mannitol, or if you have hyperglycemia. When you have given a diuretic, then your sodium will be high. In patients with acute interstitial nephritis, in aldosterone deficiency, in late obstruction, urinary obstruction. Fractional excretion of sodium will be low of less than 1% in pre-renal failure, in renal vasoconstriction like hepatorenal syndrome, NSAIDs, scleroderma, sepsis, and in acute GN. Early urinary obstruction might show less than 1% fractional excretion of sodium. Occasionally, in non-oliguric ATN, you still also see less than 1%. One of the tests that is very helpful, but often not handled properly, will be urinalysis. No? So urinalysis, you check for the color. So for the color, normally it's light yellow or amber. So what can alter the color of the urine? Intake of antibiotic like rifampicin, the anti-TB medication, it will make your urine orange, really like an orange juice, no? So that's why when you prescribe anti-TB medications, you have to warn your patients that their urine, their sweat, their tears will turn orange, no? So about red, when you have hemoglobinuria, you will have red urine. When you have rhabdomyolysis, the myoglobinuria, you will also have red. When they taking beetroot, then you will have red. Black or brown, presence of blood will also, like especially glomerular, will have tea-colored urine, di ba? Then porphyrin, homogentisic acid, melanogen, the antibiotic imepinem, and metronidazole will turn your urine brownish. And the intake of levodopa, the use for Parkinson's disease, no, medications for Parkinson's disease. In the Philippines, patients can come, would say they have pinkish urine, usually because of food intake. The bagoong, what do you call that in Bisaya? So that could, because of the color pink, so the food dye can cause pinkish urine also. Next would be the specific gravity. Measurement of solute load in the urine, and is measured by the weighted float known as hydrometer. So increase markedly by proteinuria and glucosuria. That's the reason why I said that specific gravity will be helpful to see the state of hydration of a patient, provided that they don't have proteinuria and glycosuria. High in volume depletion. Whether you fast or you drink, it remains fixed at 1.010. That's what we term as isostenuria. This is characteristic of chronic kidney disease. The kidneys lost its concentrating ability. So fix of 1 to 1.005, you see this in patients with diabetes insipidus. Next is the pH. The normal pH of the urine would be 4.5 to 8, but usual of 5 to 6. pH of 8, despite metabolic acidosis, is a characteristic of acute tubular renal tubular acidosis. So when consistently 8, okay, normally if you have metabolic acidosis, your kidney will excrete the acid. So you would lower your urinary pH. When it's very consistently high, you would think of renal tubular acidosis. Or urine pH of 8, more than 7 so it's 8. You see that in patients with urine infection, with urea splitting organisms like Klebsiella pneumoniae, Proteus vulgaris. So your pH would always be high, urinary pH. How about protein, no, in the urine? Protein excretion is usually less than 150 milligram per day, or 140 milligram per meter squared in pediatric. The normal urine protein that you see, majority is the Tam Horsfall protein. Albumin, usually you don't see that. Okay, that's a big protein man. So routine dipstick only measure albumin, and this usually should be negative. No, it should be negative because albumin is, once you have albuminuria, that is abnormal. So proteinuria is a major manifestation of renal disease and a dominant risk factor for deterioration. So you can measure urine protein by 24-hour urine collection together with your creatinine clearance, or you can use a spot urinary protein crea ratio, especially in children when you cannot instruct them to collect 24-hour, then you can use the urine protein crea ratio, preferably the morning urine. So provides an accurate quantitative measurement on single morning urine specimen. So a ratio of 0.2 milligram protein per milligram creatinine equates to a 0.2 grams of protein for 24 hours. So microalbuminuria, increased urine albumin excretion that is below the dipstick detection. No? So usually we detect it beyond 30, ano yan, but less than 30, you don't see it in the routine dipstick. So it has been evaluated in diabetes mellitus and showed prognostic signs. No, so a presence of microalbuminuria would mean you have malfunction, dysfunction of the endothelial dysfunction. So it not only pertain to the kidney function, but also the cardiac. So the entire endothelial function. So normal albumin excretion is less than 30 milligram per day. So about urine microscopy, we check for the WBC, RBC, the CAS, the crystals, and the presence of epithelial cells. The squamous epithelial cells is the epithelial cells of the outside, no, vaginal wall. No. So before you interpret a urinalysis, you look at the epithelial cells. If the epithelial cells should be rare or few, if it's moderate or numerous, many, the comment there is many, moderate, you would have to ask for another urine analysis, urine for a urinalysis specimen. Okay, this means this is improperly collected. So for routine urinalysis, you have to instruct your patient to collect midstream. So the first drop should be discarded, should not be collected. Collect the middle, do not collect the last drop. So that's the midstream urinalysis. So CAS, hyaline CAS is normal. It's normally seen in a normal individual. A granular CAS, normally it's not seen in a normal urine, but after a strenuous physical activity, sometimes you see granular CAS without any renal disease, no? But definitely a granular CAS, it can be seen in all form of renal disease. RBC CAS, when you see an RBC CAS, it would mean glomerular disease, a glomerulonephritis. WBC CAS could be acute pyelo, acute interstitial disease. Crystals. Calcium oxalate and uric acid crystals can normally be found in a normal individual, normal urine. So when patients will tell you na, Doc, I have high uric acid, ask them, did you have a blood test? They will say, no, Doc, daghan uric acid ang urine. That's not hyperuricemia. High uric acid would mean you have to check the blood. Uric acid crystals can normally be seen in a normal urine. On the other hand, cystine crystals is abnormal. When you see that, it would give you a diagnosis of cystinuria. Coffin lid crystals of magnesium sulfate is also diagnostic for struvite stone. So these are the white blood cell. No? So these are white blood cells. So nucleated cells siya. These are red blood cells. If you look at the cells, it's monomorphic. It means it's the same size and shape, no abnormal shape of the RBC. Then most likely the RBC, the bleeding is below. No, it's not. It's after the glomerulus. Whereas in comparison, these are the WBC. Okay. Phase contrast microscopy, you would see dysmorphic cells. So there's acanthocytes. So there are deformed cells. Acanthocytes. Those are acanthocytes. For crystals, the dumbbell-shaped crystals are the monohydrate calcium oxalate, and the envelope shape is the dihydrate. So that can be seen, no, in a normal. This is the one, the hexagonal crystals. These are the cystine crystal. This is abnormal crystals to siya. The coffin lid crystals, that's the magnesium ammonium phosphate crystals, triphosphate. So these are abnormal. This is, if you see this, you would have to suspect, o kung naunang urinalysis and they report a coffin lid crystals, you would think of the patient having a stone and a struvite stone, an infected stone, probably a staghorn calculi. Uric acid crystals are this, no? Patients who take sulfonamide might have precipitation of sulfonamide, and it would look like this. Rosette. Epithelial, look at this. Is it clear? This is in comparison when you try to see in the urine sediment, the bigger cell is an epithelial cell. This small one is a white blood cell count, a white blood cell. Okay, so it's bigger ang epithelial cell. So when you see an epithelial cells inside the CAS, then that's an epithelial cell CAS. And if you see the WBC inside the CAS, then that becomes a WBC CAS. So this is a clearer picture of tubular cells, epithelial cells. And this is the WBC. So it's bigger siya, no? So this one is found in the CAS. So that is WBC CAS. Epithelial cell CAS. This one is what we call as a muddy brown CAS, no? So it's really brownish, and these are all, if you see this, if you look at this in a high power field, these are tubular cells inside the CAS. When you see RBC, so RBC is a ring-like without nucleus. So we see that inside the CAS, that is an RBC CAS. So this is an example of the WBC CAS. A fine granular CAS, it means that compared to hyaline, it's clear, but it's very fine that you cannot see a cellular structure. A waxy CAS is a very broad CAS. This is seen in patients with chronic kidney disease, late chronic kidney disease. The hyaline CAS is narrower. So this one, waxy CAS, there's mga okay, so this one is tubular cells. So this is a CAS. This one has a partial. Those are epithelial cells inside a CAS. But the significant here is the waxy CAS. No, it's also a broad CAS. Fatty CAS, it's seen in nephrotic syndrome. You will have fat globules inside the CAS. This one is a squamous cell epithelium, the one beside the waxy CAS. So this is a summary of when you look at the sediments. That's why, as I mentioned, urine sediments would be helpful in identifying and helping you diagnose your cause of your AKI, aside from your history and your thorough physical examination. So if your sediments are normal or very few, you might consider the pre-renal, the post-renal, the arterial thrombosis or embolism, or a preglomerular vasculitis. But if it's abnormal, if you see an RBC CAS, that is for GN and vasculitis. For WBC CAS, it's either interstitial nephritis. It can be seen also in GN. It can be seen in pyelonephritis, in acute rejection, or a malignant infiltration of the kidney. If you see a renal tubular epithelial cells or a pigment CAS, you would think of ATN, myoglobinuria, hemoglobinuria, tubulointerstitial nephritis. You have a granular CAS, it could be seen in any diseases. It could be GN, ATN, vasculitis, and tubulointerstitial. When you have eosinophiluria, so you would have to stain the sediments, you would have to think of allergic interstitial nephritis, atheroembolic diseases, and it can be seen. So crystalluria, so specific. So calcium oxalate, if it's really a lot, it's very abundant calcium oxalate, you would think of ethylene glycol, but it's just few calcium oxalate, that's normal finding. In the uric acid is also, it's filled up ng uric acid crystals, then you would have to think of acute uric acid nephropathy, like in tumor lysis syndrome and everything. So that is the summary for the urine sediments. So in summary for the AKI, when you have, when you have elevated creatinine, you assess the baseline kidney function is available. You get an history, ask them, do you have a copy of your lab result before? Then look it up. If serum creatinine is elevated at baseline, then you would have to think probably this is chronic kidney disease. So you look for the chronic kidney disease diagnostic workup. If the serum creatinine is more than 1.5, especially if they're very common in patients who got admitted, normal creatinine initially, after 2 or 3 days in the hospital, when you repeat the creatinine, it went up. If it's more than 1.5 from the baseline, and then you would look, the first thing you can say, aside from history, again, examining the patient and getting a history, then you get an ultrasound, look for any obstruction. If there is obstruction, you might need, if it's just bladder outlet obstruction, you can insert a polybag catheter. If it's an ureteral obstruction, then you would have to refer it to a urologist. No evidence of obstruction, then evaluate, get sediments and everything, then get history. Is there new medications given? Is there a procedure that was done? So if you're thinking of pre-renal cause, then you might try IV fluid resuscitation. If it's responsive, continue with supportive treatment. If it's non-responsive, then you would think probably, if this is pre-renal, it already went into ATN, then you have to evaluate what it is, then manage accordingly. I think that's my last slide. So is there any question? You can open your any question or clarification? Sorry for the interruption kanina. Any questions or clarification from the, it's a long topic, or anything that you have read that you want to clarify? Your topic now is nephro, right? So even if it's not related, you need clarification, I'm happy to try to explain it to you. Wala na?
And so far, Doc. Thank you, Doc.
Okay, sige. If there's no questions, I think that's it. Thank you.
Thank you, Doc.
Thank you, Doc.
Thank you,
Thank you,
Doc.
Doc.
Thank you, Doc.
Thank you, Doc.
Thank you,
Thank you,
Doc.
Doc.
Thank you, Doc.